I think for most of our B-cell lymphomas, the clinical diagnosis of the disease is made by multidimensional characterization of the tumor, including genetics. In large cell lymphoma now, we routinely test for oncogenic aberrations in genes like MYC, BCL2, BCL6, and others as part of the routine diagnostic workup. But one key challenge has been how these genetics inform the treatment. So we have identified determinants of risk of good or bad outcomes, but really have had few clinical studies to show that picking a particular therapy for a particular genetic aberration, the biomarker by treatment interaction is meaningful. And there's a lot of controversy about this, especially in the last few days, based on results presented at the European Hematology Association meeting in regards to use of, for example, more intense regimens for double hit lymphomas and so on. So I think we have few examples, unlike many solid tumors, where precision trials have been done with biomarker-driven strategies to pick therapies, where we're using individual genetic lesions to pick therapies. I think the notable exception is mutations in the gene EZH2, as informs targeting of EZH2 with drugs like Tazemetostat. But I think there are lots of opportunities to take the genetic information and do studies of active agents targeting these pathways, especially with tools like liquid biopsies to genotype them as a non-invasive window into tissues that may be difficult to get.